Thank you, Patricia. I'm very happy to see this packed room today, this very packed audience, to discuss this very important topic of elimination of hepatitis B and C. Coming to Europe, I'm an academic as a background, so I cannot talk about political action unless I have good data. It's absolutely a crucial point. And I just found out that the background information is actually one of the goals we have to reach, in fact, because the data we have about Europe, despite what we know, or what we hope to see, is not exactly what we need. We need the good data today because especially we have new drivers of the epidemics. We've been kind of downplayed until now, especially immigration drivers, which need to be updated with new good data. And the ECDC is very active in this sense. So when it comes to chronic hepatitis B, essentially the epidemic hepatitis B in Europe have been changing over the decades. I used to be, when I was a student, to see hepatitis B, E antigen positive hepatitis B. Now it's no longer the case. The epidemic has evolved towards anti-E. We essentially see genotype D today. We see a recrudescence of hepatitis delta due to immigration. At the same time, a vaccination effect has been huge across Europe because of plans being implemented almost everywhere, with some delays in some countries. Effective therapy has been available for many years, but at the same time the data again is quite poor and out data. We need very precise and better data, especially on health burden, to do good estimates. You see here the classical picture depicting the hepatitis B epidemics in Europe. You see the usual gradient we see from north to south, to west to east. Some countries are heavily affected, like Turkey and Moldavia and Romania and Albania. And you see from some countries the epidemic is very, very negligible. Like in Switzerland, only 0.35%. For many others, it's very important on the other end. And one of the most important drivers has been stressed by many experts is the immigration. The origin of patients we see today in our outpatient care units is essentially due to immigration. 95% of my patients are foreign-born. And this is very important because this means different genotypes, different genetic background, a different approach to, also from a cultural point of view, to treatment and the general management of these guys. For chronic hepatitis C, the situation is kind of different. The prevalence has been declining over time. It's essentially due to the drivers, essentially mortality, which is outpacing the input of elimination. The elimination goal is probably cynical, is being helped in this way, unfortunately, and I heard officers saying that we may actually just consider the cynical option of waiting until the epidemic dies away. But I heard that. I will make no names, of course. But the proportion of those cases at the same time is increasing. This is a troublesome aspect of these epidemics. We have a lot of good data and modelizations, which is fostered by the advent of DAA. When big business entered the arena, of course, is promoted new studies on these in this respect. And they're just showing one of these, which has been done by Homi Razavi's group at CDA, showing clearly how the diffusion of hepatitis C across Europe is quite diverse. One of these estimates, this is a very conservative estimate, is stating probably about 8 to 9 million people are living with hepatitis C across Europe, with major differences, of course, among countries. Also see in this figure the distribution among different genotypes. But I would like to underline that estimations are quite diverse again. Because look at the Mod Hanafia estimation was suggesting that the number of viremic persons may be twice as big as what Dr. Homi Razavi published last year. So there is still a lot of work to be done in terms of epidemiology. As I said, the prevalence is decreasing. You see the blue line here is showing clearly by 2030 the number of viremic patients may be half as big as it is today. It's very important, of course, to take into consideration when you want to estimate the health burden. But the health burden is essentially due to advanced stages of disease, and the number and proportion of advanced stages of disease due to the aging of the infected population is increasing over time and will reach its peak at around 2030. There is a notable exception in this case is France, and the reason for that is because traditionally there is a very sensitive government to hepatitis issues in France, and not only that, the treatment uptake as a consequence being extremely high compared to other countries. The problem is that if you maintain the same treatment uptake today in most countries, the efficacy of drug being increased, despite that, the impact of the health burden in 2030 will be affected only minimally, which in other words means that we must absolutely increase the treatment rate if we really want to decrease the mortality and the health burden which is associated with late stages of disease. You see in this figure what is the treatment uptake. Of course, France is a good guy, but many countries are not really following on this. And for some, like even Switzerland, which is a rich country, only 1% of the infected population is treated per year, which is too low to impact mortality in the long range. And this figure is showing how much we should increase the treatment rate in different countries across Europe in order to reach this goal, a very optimistic goal of reducing prevalence by 90% by 2030. In some countries, a lot of work to be done, you see here, even rich countries. There are some new challenges which might take into consideration when it comes to the inputs of the epidemics. One is the very troublesome epidemic of hepatitis C among homosexual men who are HIV infected. These very good data coming from the Swiss HIV cohort study show that the incidence of new cases among homosexual men who are living with HIV has increased by a factor of 20 in the range of 15 years. So this is extremely troublesome. That means that we have a lot of work to be done and reach out to these guys in order to curb the epidemic. And the other important point is that immigration, as I said, has been traditionally a major issue for hepatitis B. But hepatitis C should not be neglected either, because for many countries, in fact, the input from immigration is quite significant. This is depicting a general overview, but let me show you what is the case for Switzerland, where we have a kind of a precise estimates. This is the usual way we look at the inputs and outputs of the viremic pool. And you see here acute infections progressing to chronicity, viremic immigrants, those who are cured, who drop off the pool, those who die either because of hepatitis C or other causes, and those who migrate abroad. If you look at the numbers, we have numbers over the last decade, you see here very clearly that the number of viremic immigrants is overtaking those who become chronic after acute infection, endogenous acute infection, let's call it that way, by a factor of at least 2. And this factor has been completely neglected until now, so we should absolutely consider the input of immigration. Where do we stand? So very few countries actually this multi-pronged strategy to, especially when it comes to recognize viral hepatitis as a public health priority. I never hear about priority. The word priority is a key word which is completely missing from political action. This is very, very disappointing situation. And all the other points, you know them very well. So where do we get this data? There are some dedicated websites. This was set up by Peter Cebolli a few years ago, the Health Consumer Powerhouse, and is extremely detailed, of course, just to illustrate the situation in many different countries across Europe. We're not going to describe this figure, of course. There's no use to do that. I just wanted to point out that this data date back 2012 and has not been updated until now. So the advent of drug against hepatitis C has fostered a lot of new initiatives in this sense. There are literally mushrooming these websites. This was sponsored by big pharma, as you see here. There is only a test version available until now, soon to be launched and made public. Is intended to be a resource for public health data, to provide data to inform politicians about the situation of viral hepatitis in Europe. And there are many other similar initiatives. I really welcome this money being invested for a very good cause by the industry, of course. And the result of these websites is to classify countries in good guys and bad guys, if you can allow me to say so. But again, the updating the disease size is problematic. Again, you see here, for example, Portugal is marked as no information provider, but we know Portugal is one of the best guys across Europe. We have a very good national action plan, especially when it comes to treatment. And I will come back to that, of course. Then there is a very welcome, again, initiative from the European Society for Clinical Microbiology and Infectious Diseases. They sent out questionnaires to KOLs across Europe. to ask about the national attitude, especially for example, just simple question, reimbursement of screening assays. Are just serology assays being reimbursed freely everywhere despite the indication? Or elastography, which is a surrogate way of assessing a fibrosis stage. And what about treatment, of course? That's a very important point. And you see here too many red boxes. It's just summarizing how the treatment access is available in different countries for encounter hepatitis C, and illustrating lower and upper middle income countries updated to the last month. You see here too many red boxes, meaning that drugs are not even available. I'm not just talking about reimbursement here. We are not to that stage. They are not even available in the market. Situation is much better, of course, for high-income countries, which is stressing again the diversity of the situations across Europe. But again, you see a lot of yellow boxes, which means the drugs are there, but the access is heavily restricted. And of course, price is driving restrictions during the negotiation with the licensing authorities. And there is a fifth website is maintained by a private university, and is very, very detailed, contains all the documents related to the national action plans. I invite you to connect to this website. It's freely available, all this data. It's very interesting. In showing, for example, how France, again, want to underline this aspect, has been a very good guy since decades, with the 3 different action plans over the decades. And this was the conclusion of the expert panel, suggesting for the first time, I see, to screen according to a birth cohort strategy. This has not been implemented, unfortunately. Spain is also very good, guys. They've been treated 42,000 patients. But despite, again, the fact that they were launching a seroprevalence survey, this has not been implemented at all. It's been kept on hold due to budgetary restrictions. So money is, again, an issue, even for a country like Spain. England has a national action plan. They are scaling up the number of patients being treated over time. And you see here 6,000 treated until now, planning to increase to 10,000 per year and up, depending on the screening policy. Portugal is probably one of the best guys, together with Georgia, I would say. You have a very good national action plan. And I also want to underline one aspect, that you are refunding screening for all those who ask to be screened. So despite the fact that most countries screen only based on risk factors, if you want to undergo a screening assay, you can get it and you get refunded. Portugal has also planned to treat 95% of all infected patients. This is quite amazing. You're only excluding those with a very short life expectancy and those who do not want to be treated, which is, of course, is obvious reason for not to be treated. And you've been treating until now, the data is available online, about 7,000 patients out of 13,000. So 7,000 as we speak is quite impressive achievement. I really want to congratulate Portugal for this. Now, just conclude and sum up. I mean, we absolutely need a very strong collaboration with patients. I'm insisting on this aspect. The situation is not really replicating what we've been seeing the past decades in the HIV field. We need the strongest voice from the patients' organizations and the public opinion to inform and to change the political action. Of course, I welcome what is going on with the European Liver Patient Association. This picture is illustrating the very good relationship going on between EASL and HELP, of course, and also with some selected politicians in the European Parliament. I thank the member of the European Parliament, Friends of the Liver Group, for their extremely helpful action and sensitivity towards our problems. So my conclusions are that data on epidemiology, even in a rich area like Europe, and national studies exist, but it's difficult to find an access. We need more work on this point. Few, if any, countries have a very comprehensive, well-resourced national action plans. I could count them out of the fingers of one hand. One problem we have to tackle in the future is a complete lack of transparency in the pricing, a wide variation in drug prices across the region, which account for different approaches and availability of the drugs across Europe. We are a very long way from achieving WHO targets, unfortunately. There are countries that are showing the path, the right path, and I want to commend what Georgia and Scotland, also I did mention Spain and Portugal, are doing. And also, of course, I welcome the interaction with the Liver Patient Association. But what we need to achieve to implement the strategy, of course, I'm insisting on this point, to inform a policy and to make estimations, also in terms of budget commitment. We need good data, because that's the only way to put pressure on politicians. But at the same time, to get good data, we need politicians. So it's a kind of a vicious circle. And to break this vicious circle, probably we need very strong patients' organizations and the public opinion, a favor of public opinion. And of course, the health academicians are working at all these levels all together to reach these goals, which I hope is not too optimistic, but reachable within my generation. Thank you very much for your attention.